RetinaRounds, episode number 126. Small to medium-sized macular holes have a very high success rate with vitrectomy and ILM peeling. But what are your options when a macular hole fails to close after attempted primary repair? That's the topic we'll discuss in today's video, presented by guest surgeon Dr. Bertan Cakir, now a second-year vitreoretinal fellow at the Byers Eye Institute at Stanford University, and his attending surgeon, Dr. Ehsan Rahimy, a vitreoretinal specialist at Palo Alto Medical Foundation and adjunct clinical associate professor of ophthalmology at Stanford University School of Medicine. This week we'll be featuring surgical cases supervised or performed by Dr. Rahimy, so please stay tuned for more great videos. Let's see how Drs. Cakir and Rahimy tackled this case. Their patient is a 73-year-old male who presented with several months of progressive vision loss. He previously had a macular hole in the right eye that was successfully repaired with vitrectomy, ILM peeling, and C3F8 gas implantation in the right eye, and he's pseudophakic in both eyes. Here's the OCT of the left eye demonstrating a small to medium-sized, full-thickness macular hole. There is a cuff and CME at the edges of the hole, all factors that confer a high likelihood of closure with surgery. The patient's vision is 2100 in the affected eye, and Drs. Cakir and Rahimy appropriately decided to perform a vitrectomy with ILM peeling and gas implantation. Unfortunately, following uncomplicated surgery, the patient's macular hole remained open. Here's the OCT following dissolution of gas, and you can see a largely unchanged macular hole configuration with stable vision. So what would you do now? Well, you have a number of options, and let's go through these. One option would be to perform a broader ILM peel. And we'll show you in the video that the ILM peeling was pretty extensive during the first surgery, although it didn't extend all the way to the arcades, but a broader ILM peeling probably wasn't going to make much of a difference in this case. Another option would be to perform the SWIFT technique described by Dr. Humayun Tabande and colleagues. SWIFT stands for Superior Wide Base Internal Limiting Membrane Flap Transposition. This technique can be used in primary repair or in reops when there's enough of remaining unpeeled ILM. And basically the technique requires a broad-based superior ILM flap to be fashioned with the hinge close to the previously peeled area of ILM. The flap is then inverted to cover the macular hole, and in their series they achieved a 94% closure rate. And their series included large and extra large macular holes, chronic holes, and myopic holes. If you haven't already, be sure to check out their publication in Ophthalmology Retina in 2021. Unfortunately, this too wasn't an option given the degree of ILM peeling that had already been performed during the primary surgery. So what other options do we have? Well, we can peel an ILM-free flap and position it over the hole. ILM-free flaps can dislodge, and the use of viscoelastic can be helpful to keep the flap in place. Other ocular tissues can also be used to cover the macular hole, including the posterior capsule, although this patient already had a posterior capsulotomy. A macular stretching or a submacular bleb creation can help to create more laxity in the inner retina and to loosen any retinal and RPE adhesions that can prevent the macular hole from closing. And then finally, more aggressive maneuvers like amniotic membrane transplants and autologous retinal transplants can be employed, although these are typically reserved for much larger macular holes. In this case, Drs. Cakir and Rahimy decided to go with macular stretching and submacular bleb creation. Let's check it out. Okay, starting at the beginning of the case, you can see here that 25 gauge trocars are being placed. There is some residual gas from the prior surgery, which is removed with the vitreous cutter, and the retinal periphery is inspected, which looks to be within normal limits. Now some tissue blue is being instilled over the posterior pole to visualize the extent of the ILM peeling. Now a drop-on lens is used. And when injecting the tissue blue, you can use the vitreous cutter to reflux the tissue blue into the eye, and also you do want to try to direct the jet of the tissue blue injection away from the macular hole. Now intraoperative OCT is being used, and you can see that the configuration of the macular hole is very similar to that which was seen in the preoperative OCT. Using a flex loop here, very gently the retina is being stretched, and here on the nasal side you can see that the flex loop is in a more vertical configuration where you have to be a bit gentler using it in that configuration as opposed to when it's in the more horizontal configuration in the temporal part of the macula. Here ILM forceps are being used to peel any residual ILM. The extent of the ILM peeling here is pretty thorough, and so it's a bit surprising that the macular hole didn't close given the extent of the ILM peeling performed during the first surgery. But here Dr. Cakir is peeling just a little bit more ILM, trying to regrasp at the edge of the previously peeled area and extending that peel even a little bit more further towards the arcades. Some additional tissue glue is being used, and just inspecting the areas that have already been peeled. And I think Dr. Cakir is pretty happy with the extent of the ILM peeling. Now we're going to move over to the submacular bleb creation. You can see here that an extendable subretinal cannula is being used, and is being used in the inferior macula to begin with. Now, when creating blebs, you can either do this with pneumatic assistance using a microdose injection kit that's supplied by Med1 that can be connected to the VFC functionality of the vitrectomy platform. Or in this case, a skilled assistant, in this case Dr. Rahimy, is manually injecting BSS while these blebs are being created. And you can see that multiple blebs are being created just to make sure that the full extent, 360-degree extent of the macular hole is separated from the underlying RPE. Now, Drs. Cakir and Rahimy are using the intraoperative OCT just to confirm that they do have elevation and separation of the perifoveal macular hole from the underlying RPE. And you can see here in multiple locations that it looks like there's more laxity of the retina, that there's certainly some subretinal fluid. And you can see in certain areas where it looks like the macular hole is almost reopposed. So again, the purpose of this is to release any adhesions of the retina to the underlying RPE that may be holding the retina back from closing, but also to create, paired with the stretching maneuver, to create a bit more laxity in the retina to encourage macular hole closure. Now again, going back to the flex loop, again doing a little bit more macular stretching to encourage the edges of the macular hole to come together, and looking at that using intraoperative OCT, you can see that those edges of the hole are pretty well approximated. Now an air fluid exchange is performed, the trocars are removed, the wounds are sewn shut using a plain gut suture, an air gas exchange is performed here, and all those wounds are sewn shut. So here's the postoperative outcome. This is the patient at postoperative month 1. And you can see now a successful closure of the patient's macular hole. There is some residual gas on the infrared image to the left. The patient's vision is still 2100. And on the B scan, there is still some ellipsoid zone and ELM disruption in the fovea, but this can certainly improve with time, and we expect that there will be some subsequent improvement in the patient's vision. Overall, a very beautiful application of submacular bleb creation with macular stretching, and certainly an outstanding anatomic postoperative result. We want to thank Drs. Cakir and Rahimy for sharing this case with us, and thanks so much for watching. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.